Good afternoon and welcome everyone to History at Home at the Australian National Maritime Museum. History at Home is a new talk series that will be on every Tuesday at 4 p.m. And it's so great to see so many people have joined in today's session. I'm Dr. Stephen Gapps, a senior curator at the museum, and I'll be your talk moderator this afternoon. The Australian National Maritime Museum acknowledges the Gadigal people of the Eora Nation as the traditional custodians of the Bamal, the land, and the Badu, the waters on which we work. We also acknowledge all traditional custodians of the lands and waters throughout Australia and pay our respects to them, their cultures, and to elders past and present. The title of our session today is, Does Quarantine Really Work? Obviously, this is a very topical question at the moment, and many of us are struggling with lockdowns during this pandemic. I think today's talk will offer some important context to the nature of quarantine, particularly as an historical practice. We have two wonderful speakers today. I'd like to introduce historian Dr. Peter Hobbins, who many of you may know has written extensively about medical history, and in particular a book on the quarantine station at Sydney's North Head. And Peter will be in conversation with David Muscatello. David is an Associate Professor in Infectious Diseases, Epidemiology at the University of New South Wales. He has a PhD in the epidemiology of pandemic and seasonal influenza. He also has many years' experience working in government as an epidemiologist. Now, the session will begin with a 15-minute talk from Peter, which will be followed by a 25-minute conversation between Peter and David. There'll be around 20 minutes at the end for audience questions. Can I ask everyone to please type your questions into the Q&A box, and we will gather the questions as we go and hopefully answer as many as we can. So thank you everyone for joining us, and I now hand over to Peter.
Well, thanks, Stephen. And I'd just like to say thank you everybody for joining us, and I'm joining you from Bidjigal, Wongal and Gadigal land here. So as a historian, I've spent many years poking through the records of Sydney's North Head quarantine station, which you can see in this slide, just behind the bow of the ship there, the stern of the ship, I should say, that series of structures on the hillside there. Now, the idea of quarantine is quite simple. It's a way of keeping people who are infected with a contagious or infectious diseases and those they've been in contact with away from other people who are healthy. And part of that process means allowing the disease to run its course in those people who've been infected so that they're quarantined for longer than the incubation period. In other words, the disease is completely gone before those who have been sick or been in contact with them are allowed back into contact with the healthy population. Now, quarantine is quite an old idea. It dates back to the Middle Ages, particularly to the 14th century with the Black Death or bubonic plague that affected Europe and large parts of Asia at that time. And the idea of quarantine developed particularly in the Italian city-states around the Mediterranean, where the idea was that people arriving either on boats or on land from potentially infected plague areas were asked to wait out for 40 days, or quarantena, which is the origin of the idea, but also the word for quarantine. Now, what I'll be talking about today primarily is border quarantine, including maritime, in other words, on the oceans, land-based and airport quarantine as well. And one of the messages I really want to leave you with today is that quarantine can be highly effective. It really has had an important role in preventing or delaying the entry of dangerous infectious diseases into our community, including epidemics and pandemics in the past. But of course, effective quarantine requires us to understand which diseases can be transmitted between people and how that happens as well. And historically, we've had very different ideas of what causes diseases, how they might spread, and how we might prevent that spread as well. Australia's had a very impressively long record of successful maritime quarantine, keeping out ships that might be bringing infectious diseases ashore until they're safe. And we've also had a very strong tradition of effective public health interventions for at least the last 150 years as well. And in order to deliver both good public health and effective quarantine, we need laws, appropriate facilities, and highly trained personnel, as well as we found out in the last couple of years, the cooperation and the goodwill of all of us in the public as well. Now, quarantine, unfortunately though, is never perfect, and it's had many problems that have emerged over the years that compromise its efficacy. And I'm going to go through a series of those problems now, not to completely disparage the idea of quarantine, but just to show some of the cases where things have gone wrong and that we've had to deal with them in order to make sure that they're as right as possible in the present. So one of the classic problems is asymptomatic disease. In other words, disease that doesn't show any visible exterior signs or any internal symptoms that people feel that they're suffering from. And that can be because some diseases infect people without causing any immediate consequences, or because they may have been infected and then gone into some form of remission as well. And so some diseases that may be asymptomatic if they came to this country would include rabies, which is terribly feared around the world, but it has an incubation period of up to 90 days before signs and symptoms start to appear. So you could pass through our borders without having any hint that you'd been bitten or were suffering from rabies. Malaria is another classic disease that can cause a pronounced initial set of signs and symptoms and then become quiet again. And so people can feel that they're over the disease only to find that it comes back when they've returned home. And of course, one that many of us will have heard of over the last few decades is HIV, which first arrived in Australia in 1981. Now, it's likely that the first Australians who developed HIV picked that up in San Francisco and other places in California and arrived in Australia feeling perfectly well. And it took a long time, months if not years, before their diagnosis was made. And of course, there was no test for that at the time, and there was certainly no quarantine measures in place in those early years. Now, another problem that can face quarantine is that diseases arrive unseen. In other words, that infected patients or vectors for the disease, including animals that can transmit the disease between other animals, but also to humans, that they're not detected at our borders. So to give you an example that we can see on the slide here, bubonic plague, the very same Black Death that we saw in the Middle Ages, was spreading around the Pacific in the 1890s. And certainly the Australian colonial quarantine authorities were quite aware of the risk. And yet, despite all of their precautions, in March 1900, cases suddenly started appearing among the population of Sydney, particularly in the dock areas. And yet there was never any diagnosed case of bubonic plague aboard any of the ships coming into Sydney Harbour. So it's possible that the plague actually came ashore not with humans, but with rats that had travelled on the ships and that were therefore harbouring the bubonic plague bacillus or bacteria. And so, in fact, most of the quarantine measures in place at this time had to be actually about protecting wharves from rats and making sure that we cleared rats out of any of those maritime areas. So effectively, it was an animal quarantine introduced to help improve human public health. Now, there's another similar problem that often can affect quarantine efficiency as well, which is misdiagnosis. Now, that doesn't necessarily mean that health practitioners aren't good at their job. I think, many doctors and other health providers who worked in quarantine facilities were very good at diagnosing these conditions. But many diseases can present in unexpected ways. It can be a particularly mild case where it's not suspected that somebody's suffering from a serious infection, or their presentation, the way that they actually look and sound and feel, can be unusual, can be out of the ordinary, and therefore not spotted for the disease that's actually underlying it. And to give you a classic example, smallpox was a highly deadly, highly infectious disease that affected many parts of the world in the 19th century. And yet by the 20th century, a milder version of it was spreading around the world. It was still very infectious, but the death rate was about 100 times less than it had been in the previous century. And we saw many cases of it arriving in Australia in the 20th century, including the one you can see on the screen here, where the New Zealand ocean liner Arangi arrived in Sydney from Vancouver. And there appeared to be a healthy group of people on board, so they were all allowed off. But then it turned out that several of them were actually harbouring mild cases of smallpox. Now, in its mild form, smallpox looks a bit like chickenpox or even like a bad case of acne. And so that's why the patients who were suffering from it weren't at first diagnosed. And in fact, they travelled onwards as far as Perth before the initial cases started presenting to doctors in Sydney and there was a hasty degree of contact tracing and quarantine that followed. Luckily, no outbreak ensued. And if you're interested in that particular incident, including the case of lifelong quarantine for an American donkey who was caught up in it named Hot Beans, then jump onto our website and track down issue 133 of our magazine Signals, where I've written a little bit more about that episode. Now, some of the difficulties with quarantine can also be deliberate as well as accidental. And that often comes down to dishonest patients who have a disease or crew aboard ships as well, because of course they want to get into port, dispense their cargoes and passengers as quickly as possible and get back out to sea again. So for them, quarantine is a major interruption into their livelihoods. And let's look at a couple of examples. In 1828, the convict ship Morley arrived in the city of Sydney. Now, several of the soldiers on board had children who were infected with whooping cough or pertussis. It's a disease that's still sometimes with us today. They chose not to tell any of the colonial authorities about that. Neither did the captain nor the surgeon on board. And what that meant was that whooping cough actually got out into the colony and affected practically every family in New South Wales at that time, including Governor Darling's one-year-old baby Edward, who unfortunately died from the disease. Several decades later, the brig director arrived in Sydney with a case of smallpox aboard, but the passengers were allowed out into the city before it became apparent that some of them were harbouring this highly infectious and potentially deadly disease. And the city was quite lucky that no epidemic ensued there. But in both cases, these evasions of the quarantine restrictions led to a beefing up of the Quarantine Act and the associated procedures. And sometimes evasion can also include escape from quarantine as well. So you can see on the slide here, Sydney's quarantine station as it looked in the 1840s. It was a pretty isolated, pretty barren looking place. But if ships were put in there, then passengers could potentially risk the overland trek to go to the area that we now know as Manly in order to get back into the city. And they were more and more likely to do that as the suburb of Manly grew and it had more and more pubs in it. And that was certainly the case for a couple of people who did escape quarantine with during a smallpox scare and were found at actually one of the local hotels. Now, the dishonesties don't end there either. So one of them is actually the concealment of cases once people have been allowed out of quarantine or once the disease has made its way into the community. So when Sydney suffered an epidemic of smallpox in 1881, for instance, we never were sure where the origin of that was. It was not quite clear which vessel had brought the disease into the city. 303 cases were identified, but the health authorities at the time knew that there were many more cases out there in the community. The problem was that the individuals and their families were often hiding those people, either because they felt they would be persecuted, particularly Sydney's Chinese population, who were being held accountable for the disease. But also many people didn't want to go into detention at that time. And in fact, there was a royal commission into the epidemic afterwards, which highlighted just how much citizens resented being put into mandatory quarantine at the time. And we saw similar reports of people deliberately hiding cases of their disease during the plague outbreak in the Sydney in 1900, and again during the 1913 smallpox outbreak in Sydney. So we've looked at people on the last few slides. Let's have a look at some of the biological problems as well. Pathogens, in other words, those microorganisms that cause disease, are quite varied and they also evolve over time. And of course, we've seen that in the last year, particularly with the various strains of COVID-19, including the Delta strain that's now in our community. So the disease itself changes its form, how infectious it is and how deadly it is in the course of infecting multiple patients. But also when individual people are infected by diseases, they can also present in multiple different ways. So there's a variation in their clinical presentation too. Let's look at another example here. Pneumonic influenza, or the famous Spanish flu pandemic of 1918 to 19, was kept out of Australia by a highly effective Commonwealth quarantine system. And that included some remote places like Thursday Island that you can see here in 1919. And that quarantine system worked fabulously in 1918, but ultimately it failed. And in January 1919, cases started appearing in Victoria. And one of the reasons it wasn't at first suspected that quarantine had been broken was that those first few patients had a relatively mild version of what had been an incredibly deadly disease through 1918. And so at first, those initial cases in Victoria were actually confused with seasonal or just the typical annual flu that goes around a community every year. And it was only recognised a little bit too late as being the highly contagious Spanish flu variant. And by then, it had got out into the community and started spreading around the country. But there was a benefit to that initial quarantine success period, which is that when Spanish flu did come ashore in January 1919, it was still incredibly infectious, but it was less fatal than the version that had been circling the world in 1918. And so, in fact, the impact in Australia was even much less than we saw in New Zealand, which was infected several months earlier. And in fact, our death rate was about a quarter of that of our colleagues across the Tasman. Now, the diversity of life also presents perhaps the final problem I'll talk about with quarantine, which is unsuspected sources. So COVID, as we know, can jump species. And of course, we had no way of predicting just how incredibly infectious it would be or the consequences of infection upon humans who are not the natural host of the disease. And we certainly didn't expect it to spread nearly as rapidly as it did. In Queensland, there are bats that harbour a disease known as lyssavirus. Now, if they bite human beings, they can actually lead to a disease effectively akin to rabies. And yet that disease isn't spread from person to person coming ashore and being quarantined, but rather it's actually coming into the community from bats that live in the natural environment. And you may be wondering why this slide is up here. Well, when the Apollo landed back on Earth, they were taken aboard the US aircraft carrier Hornet, where they were immediately put into a streamliner trailer, the classic American trailer that was converted into a temporary quarantine station aboard the aircraft carrier until it was ascertained that they hadn't brought back any exotic infections from the moon or from their time in space. So sometimes we have to deal with the unknown unknowns in the world. Now, it may seem that I've given us a huge string of historical failures of quarantine, and that's true. So I guess it does in a sense pose the question, why do we even bother with quarantine? Well, there's a couple of really important take-home messages here, I think. One is to say that the failure of quarantine can actually follow a period of initial success as well. And that success is really important in slowing or reducing the impact of major epidemics and pandemics coming into the country. And that can help us have time to adapt to new threats. So for instance, I just spoke about the Spanish flu pandemic, which rounded out towards the end of 1919. And at the very end of that year, the very first aeroplane to land in Australia from overseas came to ground in Darwin. And it was this Vickers Vimy you can see here on the slide. And so immediately, straight on the tail of that pandemic, Australians had to think about a new form of disease coming into the country. Interestingly enough, they weren't so much concerned with passengers aboard these aircraft for the first few decades, but they were actually more concerned about the spaces inside aeroplanes and whether they might harbour mosquitoes that could be carrying diseases like yellow fever or malaria into Australia. And the other point I would make about quarantine failures is that I've been talking largely about border quarantine. And as we've seen again this year, there's multiple levels of quarantine that we need to consider. And so with COVID, for instance, we've had not only border patrols, but we've also had to think about hotel quarantine, local government quarantine, home quarantine, and even quarantine within individual rooms within our own homes as well. So that finally brings me back to the original question that launched this presentation. Does quarantine really work? Well, I'm glad you asked. I think when we analyse quarantine historically, it's actually often succeeded. And of course, we tend to forget all the positive case studies when we think about some of the failures. And in fact, Australia's had an incredibly good track record at keeping out infectious diseases over the last 250 years. And analysing the times when it's gone wrong has actually allowed us to improve our laws, our systems for dealing with potentially emerging infections, and our responses to them if they do come ashore as well. So as a historian, my conclusion is that quarantine works until it doesn't. And it provides us with a critical first line measure, but we always need to have multiple backup plans, the classic belt, braces, and spare pair of trousers. Now that concludes my historical overview. What I'll be doing now is moving us to a current conversation with my colleague, Associate Professor David Muscatello. and we'll be in conversation for about 20 minutes or so, asking some questions. And do please keep adding your own questions to the Q&A box there as well. Thanks so much. And welcome, David. Nice to be joining you in conversation now. So, David, we've got a series of conversation points that we're going to go through today, and we'll see how we go with them. And I'm really dying to hear the questions from the audience as well. We'll be bouncing backwards and forwards between the past and the present, and possibly with a bit of an eye on the future as well. So I wanted to start by asking, in the 21st century, is quarantine considered a public health measure of last resort, or is it a first-line intervention?
Hello, Peter. Thanks for having me on today. I'd just like to mention that I'm speaking to you from Gadigal and Wangal lands. Now, in relation to your questions, you've actually covered an enormous amount of territory in relation to quarantine in your talk. So I think, the simple answer is that quarantine plays a central role today. And I just want to say, in relation to the point you made about whether quarantine is failing, it's when we live our lives normally protected from infectious diseases, we don't realize how much quarantine is working for us all the time. And so quarantine, in fact, is a first-line measure. We have border controls at the moment that, as I understand it, there are no cruise ships coming to Australia at the moment. And if they did, people on them would have to quarantine. And if they were able to come on shore, which they wouldn't be, but if they were able to, they would have to quarantine for 14 days in the same way that someone arriving by aircraft would. I guess then there's the aircraft quarantine. There are limits to how aircraft crew can, what they can do when they arrive here. People who are in transit can just continue through transit if they have an onward destination country, but anyone staying here has to quarantine for 14 days. And that's played a very important role in keeping us as safe as we have been up until fairly recently. And it's still working in some parts of Australia. The other thing, at the community level, it's really important to recognise that quarantine is something that's central to our day-to-day control of the local community transmission of COVID-19. As Peter mentioned, people who are cases of the disease have to isolate for 14 days. If they have contact with other people during their infectious period, those people have to be traced and they have to quarantine for 14 days. And that's happening every day right now in Sydney and in New South Wales, and it's a really important measure. So first line, I think, is the simple answer.
Great, thanks, David. And I guess, you mentioned a whole range of different types of quarantine there, including maritime and airport-based, as well as land quarantine as well. So, we're dealing with the COVID crisis at the moment, but you've been studying epidemiology, or the understanding of how diseases spread in the community for decades now. Do you think that the major risk tends to come to us through air, sea, or land transmission these days?
That's really difficult to answer, Peter. The fact is that cruise liners have played an important role at the early stages of the arrival of the pandemic in Australia for both COVID-19 and swine flu in 2009. And maybe a lot of people aren't aware of that, but in May 2009, there were cruise liners coming to Australia with people sick on board, and some of them did have swine flu, and we were able to stop those many of those ships birthing and bringing the virus into Australia. And I guess one of the reasons that cruise ships may be such a big problem is because they carry thousands of people, and they're on the sea for long periods of time. If the infection gets on board, then you can get multiple generations of the infection spreading throughout a large number of people. And that just escalates the problem to a level that's really hard to control, because countries do have a responsibility to assist people at sea if they're unwell and provide health services to them, for example. And so there are many reasons why it's difficult to deal with ships containing unwell people. On the other hand, we've got aircraft, and for me, it's surprising that aircraft haven't played a more major role early in pandemics. But eventually, people arriving by air do bring the virus. Aircraft have very good air conditioning systems, and the people are in the air for relatively short periods of time compared with a cruise liner. And so and if they do infect others on board the aircraft, then it's probably only maybe the first few rows around them. So it's a fairly contained transmission opportunity. But when they arrive, at the moment, we have, we closed our borders. We introduced quarantine for 14 days, and we'd still try and seal them off until we know they're not infectious. Then there's land. Well, the simple answer to that is that, for train travel, for example, our borders, state borders are closed to interstate trains. Freight moves, but there are rules, careful rules about what truck drivers have to do. They have to test themselves frequently or get tested frequently. It's just, there are so many details that have to be accounted for in maintaining quarantine. So I guess I haven't given you a clear answer, but I think any opportunity to arrive in the country a virus or pathogen will take. They're very clever.
It's interesting. I guess part of the answer comes back down to the nature of the disease itself. So a classic one is cholera, which is a diarrhea disease that's easily spread between people. And it led to a huge epidemic in Europe in the early 1830s. It terrified people. And in fact, that's one of the main reasons that the North Head Quarantine Station was set up in Sydney in the early 1830s. And yet, ironically, cholera has a very short interval for transmission. So we didn't see any maritime cases of cholera actually coming ashore in Australia in the 19th or 20th century until it came by aircraft in 1971. That was the very first case of imported cholera. So in fact, that was because I guess it was so easily spotted and so rapidly transmitted that it wasn't until we had aircraft that that disease was able to come ashore.
Yeah, and that's right. We teach, when in teaching outbreak control or epidemic control, determining what the pathogen is very much the first step after you've determined that there is an outbreak. And once you know what the pathogen is, if the pathogen is a known pathogen, unlike our current COVID-19 pathogen, you can understand how it behaves, its microbiology. We know a lot about the transmission characteristics of many pathogens that can cause epidemics. And if we know that, we know how they transmit from person to person, or what the vector of transmission, like mosquitoes for malaria and other diseases. If we know that, we have a much better idea of how to control it. And so that's important. And the other thing, just thought I'd mention, the cholera outbreak you mentioned in Europe was one of the main driving forces for the introduction or the beginning of international health regulations, where epidemic and quarantine control and organized communication between countries on the occurrence of epidemic diseases was instituted.
And I guess, you've mentioned a range of the measures there and the responses we have. Immunisation is another one that we didn't have a great deal of in the 19th century, apart from smallpox vaccination, whereas it's obviously on everybody's lips today. And so I guess I was going to ask how immunisation and quarantine work together. Is one strategy preferred over the other, or do they work hand in hand?
Well, I suppose the simple answer to that is that quarantine has, in Australia at least, bought us time and for the vaccine to be developed. But in pandemics of my experience, the recent swine flu and the COVID-19 pandemic, we haven't had a vaccine that we can just pull out of a box and deliver to the population at the beginning of the pandemic. And so there's this period of time where a vaccine has to be developed to allow us to protect our population and then reduce the need to have quarantine. At some point with COVID-19, we're going to be in a position where enough of our population is vaccinated, the disease, the virus is understood well enough. There's been enough transmission in other countries to say our chance of getting it in Australia or in any other part of the world is fairly similar. It becomes homogeneous, I guess, in terms of its circulation in populations. But we're not at that point yet, and to be honest, I can't say when we're going to be at that point. But vaccination is the only thing that can allow us to let down our guard, I guess.
Yeah, and I must say, interestingly, historically, quarantine and vaccination have crossed over in other ways. So, for instance, with the Spanish flu pandemic, a vaccine or several vaccines were created in Australia in 1918 and 19 basically from the sputum or the gunk that was coughed up from the lungs of patients who definitely had the disease but were held in the quarantine station before it broke out into the community. And so that vaccine was produced in massive doses and put out into the community. The only problem was that it didn't particularly work because it was a bacterial vaccine directed against a pandemic that was caused by a virus. Now, that wasn't well understood at the time, but it gave a sense of how rapidly a vaccine could be produced 100 years ago. And I think one of the challenges we face this year is not only understanding the disease, but having that requirement for really rigorous testing of therapeutic goods and then ramping up the production and distribution side, which is necessarily slower now and of course has caused a lot of grief, but it's probably better to do that than to be immunizing in New South Wales case about a quarter of the population with a vaccine that doesn't actually work.
Yep, I agree. But it's essential to have the rigor that we have in studies. It comes at a cost of time, but we have with the COVID-19 vaccines, we've been able to create efficiencies in the process that have brought all the endpoints of the various stages of testing closer together. And we've already seen that the things that we couldn't foresee, like certain, side effects of the AstraZeneca vaccine, you can't protect against those, and you still have to have systems in place, and we do have strong systems to manage those situations. Yeah, and I guess thinking about smallpox, my understanding is that the smallpox vaccine, the idea of it originated when people realized that they could expose themselves to the scabs of people who are infected with smallpox, and then if they were infected with smallpox, they got a much milder infection, and it's so in some cases that idea works, but in others clearly doesn't.
Yeah, great, and I think that leads me then, when I was talking about Spanish flu earlier, and I mentioned that it had worked until it didn't, and that was a really important pause in the evolution of the disease, and therefore it also gave the health authorities in Australia more time to prepare for when the disease actually got into the community. But it led me to wonder about how do we know when quarantine or a quarantine strategy has failed? Does one case create a failure of quarantine, or does there have to be a complete breakdown of the system there? And when we looked at these examples like the ones I illustrated in my talk, where there has been a failure, how does that assist us in planning for the next stage of response or for future interventions against that disease or similar sorts of diseases?
I prefer not to use the term failure of quarantine. Quarantine is one of many measures that we have, and every measure that we have available to us is not perfect. Masks are not perfect. They're very good, but they're not perfect. Vaccination is not perfect. Physical distancing is not perfect. It's just, we have to throw everything that, all the measures that we can come up with against our chance of experiencing a serious epidemic. I think in any case, we're always managing a pandemic, managing a severe epidemic is a learning exercise all the way through. And as you said in your talk, Peter, we use the experience of an epidemic to learn how to deal with the next one. But nature throws new things at us all the time, and we can never be completely prepared. That's really the bottom line. I did want to say one thing that I didn't mention earlier, though. We're also using, at the moment, we call it lockdowns, but in New South Wales, for example, we're not allowed to leave our local government area. In a way, that's a type of community quarantine. We're actually, even though it's quite porous, and many of us can leave for reasonable excuses, but we are required to stay contained in an area, and that is a type of quarantine, and it is succeeding, I believe, at the moment, even though we've seen cases rise, and they were rising exponentially, but they would have risen a lot faster if we hadn't seen that. We would have seen many more deaths. And again, it bought us time because now, despite some delays, we are getting our population vaccinated, and we're seeing fewer deaths than would have occurred. Even with the large numbers that we have, we would have seen a lot more deaths if we hadn't got some of our population vaccinated and introduced some of the measures that we did, including quarantine.
Great, yeah, and I think there's certainly, we've seen a lot of challenges to our ideas about practices and efficiency of quarantine in the last 200 years, but even in the last decade as well. But I think, we're getting close to needing to wrap up here, and there's a huge number of questions from the audience, which is wonderful. I was wondering if we could talk briefly about some of the incidental benefits of quarantine as well. So actually, I've certainly seen that historically, where quarantine measures can actually have unexpected benefits beyond preventing the particular disease. But I wondered if there's any that you've noticed in the most recent COVID outbreak.
Yeah, well, in fact, I believe a report's been released by the Australian Institute of Health and Welfare that looks at this question, and in the last week. And in any case, I've observed, and I know that, in fact, influenza has virtually disappeared from Australia, and virtually disappeared, as far as we know, from a large part of the globe. And whether that's temporary or not, we don't know. It probably is temporary, but quarantine, certainly, if influenza was circulating, the 14-day quarantine of international arrivals is definitely keeping out new strains of influenza, because influenza, like COVID, is constantly mutating. So I guess the other thing that's been really obvious as well is there've been a lot fewer deaths, I believe, from respiratory infections, because COVID's a respiratory infection, and the measures we've put in place have prevented transmission of respiratory infections in our community. Some of them, interestingly, are coming back, and that's really interesting. There's a virus called respiratory syncytial virus, which causes it causes common colds in adults, but it causes quite severe illness, an illness called bronchiolitis in young children, in infants, and that causes a lot of hospitalizations. That disappeared for a long time last year, but then it seemed to come back when children started getting together, and I think it might be we might be seeing it going away. So also the Institute of Health and Welfare report mentioned that because there's less mobility in the population, that there are fewer road deaths as well. So there are some very surprising benefits, despite the, and clearly we're going to see some issues with mental health, and we are seeing issues with mental health, and that's one of the unfortunate sides of it. Yeah.
Right. Well, thanks, David. We could keep chatting all afternoon, I'm sure, but that was nice to end on a very positive note there. And we've now got about 20 minutes or so for questions. So I'm going to ask Stephen to rejoin us to send questions our way. And Stephen, I believe there's a few questions for us to be dealing with out there.
There sure is. Thanks, Peter and David. That was a great conversation about history and science coming together. It's fantastic. There's heaps of questions, but I thought I'd start with one that just came in that is kind of a really basic point, but maybe you could just quickly explore it. Is a question about what's the difference between a pandemic and an epidemic?
So that's a question for me, I believe. So I guess we have three levels that we generally talk about of infectious diseases. So at the smallest level, and there's no real, it's really hard to give you a clear distinction between each level, but at the smallest level, we would say when there's a number of cases in the community in a fairly contained area, we call that an outbreak. If the infectious disease starts spreading over a large area, maybe a whole state, a whole country, or even a few countries, we call that an epidemic. But if the disease spreads across multiple countries and appears to be something that is not going to be easily contained, then we call it a pandemic. But really interestingly, the World Health Organization took the step of actually declaring a pandemic in March last year, 2020. And that was actually something they said it was a very difficult decision to come to. It's something that experts from around the world got together, talked about it, and said, okay, this is something that we're not going to control easily. It's something that's spreading in numerous countries. It's out of the bag, basically, and we declare it a pandemic. And while I don't believe there's a process for that written explicitly into the international health regulations that the World Health Organization and other countries follow, there is this kind of informal decision-making process. I hope that answers the question.
Yeah, thanks, David. I think this first question is, I think, for Peter, is from Megan, who asked that there's been many outbreaks and close calls around Australia, but do we know if this impacted on migration, especially assisted migration schemes? Essentially, did it scare people off from undertaking a long travel journey to Australia?
Thanks, Megan. That's a great question. I'll be interested in David's take on this in more recent years as well. The short answer is no, which is a little bit surprising. I think if Australia had a very interesting development with how colonists came to this country from 1788 onwards. As we know, that was initially launched mainly through the convict transportation system. And in 1815, there was a huge number of deaths aboard a number of convict ships coming into Sydney. And as a result of that, a local surgeon, William Redfern, who the suburb is named after, actually published a report and suggested that all convict ships chartered by the British government should have a surgeon aboard to make sure that the health of the convicts was looked after. And that applied to the convict system well before it applied to commercial passenger vessels. And in fact, it was only because that system worked so well at minimising the risk of disease on board convict ships that it was voluntarily and then finally mandatorily required of commercial ships in the 1830s. And so what that meant was that from the early 1830s, all assisted immigrant ships coming to the Australian colonies, in other words, those that had part funding or full funding from either the British Imperial government or the Australian colonial governments, they had to have a surgeon superintendent aboard if there were more than 50 passengers on the vessel. And that surgeon superintendent was a very powerful person. They were effectively equivalent to the captain on board the ship. They were responsible they were effectively a GP for the ship community, which might be anywhere between 100 and in some cases 800 passengers. So some of these were very large ships. And their job was to maintain the health of the patients, to vaccinate them if possible or if required, to look after their food and water and their living conditions, and to certainly isolate or put into hospital anybody who did have a potentially infectious disease as well. And as a result of that surgeon superintendent system, and the fact that ships' captains were rewarded for every person they landed ashore healthy and alive, the likelihood of dying on a ship voyage from the UK to Australia in the 19th century was no worse than if you'd remained at home in the UK at that time. So that includes shipwrecks and infectious diseases and accidents on board the ships as well. So in fact, it was a reasonably healthy measure. And part of that, and one thing that I don't think historians have explored adequately, is that all immigrants coming to Australia had to go through an emigration depot in the United Kingdom before they were allowed aboard these ships, where they were taught hygiene, in other words, washing their clothes, cooking their food appropriately, learning to use toilets, which many people had never encountered before, as well as basic sanitation measures. So for instance, washing and airing their laundry as well. So they were actually schooled in these things before they were allowed aboard ship. And the surgeon superintendent had to supervise those activities when they were on the seas. And I think it hasn't really ever been explored about how that affected public health of Australians once those immigrants arrived in the country. So that was probably a long answer, but the short answer is it was actually just as healthy to be at sea. And I don't think that the risk of developing disease or even dying in shipwrecks scared that many people off emigrating to the Australian colonies.
Peter, I have, I don't have much insight into that particular aspect, but in epidemiology, we talk about the healthy migrant effect. Mm-hmm. And basically the principle is that people who make the decision to migrate are probably a little bit more risk-taking, a bit more adventurous. That doesn't apply to convicts, of course, but to immigrants generally. And they tend, maybe because they are healthier people to start with, they have that physical confidence to endure a journey overseas and take up a life elsewhere. So it's just a sort of an interesting aside, I guess.
Interesting. Whereas in the 19th century, often people with tuberculosis, or as it was called then, consumption, were encouraged to take a trip to the colonies to improve their health and to get that fresh air into their lungs, which was thought to be able to help them as well.
I think the next question is partly for both of you. From Matthew and Daniel, it's a question about what is the most successful form of quarantine and perhaps the most successful example.
That's
a tough one.
I I guess my answer historically would be tough quarantine is the most successful in most cases. The original 40-day quarantine for bubonic plague could be highly effective. It could be pretty awful for people who were aboard an infected ship or were left outside the city walls. If they did actually suffer from bubonic plague, they were left to their fate, basically. But to have a protracted quarantine of up to 40 days obviously reduced the likelihood of transmission of disease. But it was obviously very hard on those people who were kept in quarantine as well. I guess the other thing was that most quarantine stations initially were quite isolated. They were deliberately at places far from centres of population. And so Sydney's North Head, for instance, when that was set up in the 1830s, it was a very lengthy road journey to get from the city all the way around Sydney Harbour to North Head. And in fact, it was often a lot quicker to row there or to sail a boat there. But the point was that it was a long way from the city, and then gradually the suburbs moved up towards it. And so you get an increasing tension over time, particularly by the 1870s and 1880s. As the suburbs grew closer and closer to the quarantine station, there was more and more local agitation to have the quarantine station moved further away from them, even though it was there first. So I guess that would be the other thing, that those isolated facilities, whether they were islands, for instance, Torrens Island off Adelaide, or there were some islands off the Queensland coast or Western Australian coast, or in Tasmania, where the island quarantine was often highly effective simply because it was incredibly difficult for the disease to get out until the full period of quarantine had been served. And I guess we've moved away from that practice by and large today.
And I suppose to add to that, what I'd say is that with COVID-19, it's the first pandemic that we've really had incredible mobilization of science in a way that's never happened before. We've never had such an understanding or been able to develop such a good understanding of the pathogen, the way it's spread. You know, there have been some misunderstandings along the way, but science is continuing to learn more about the epidemic, the virus, and we're able to use that information to make decisions about how to manage quarantine. You know, the fact that we isolate people for 14 days or quarantine them for 14 days is based on the science that has been learnt in less than a year. Science usually moves much more slowly than that. So I really think I'd have to say that's been a great success, even though, you know, eventually it will be breached, quarantine will be breached, but it has helped us a lot.
Thanks. The next question, I think, is a good one in trying to understand the comparison between previous pandemics. And Jackson asks, how many people died in Australia due to the so-called Spanish flu? Perhaps you could comment on the numbers and a comparison between the two.
Do you have those figures, Peter? Because
yeah, I can talk a little bit about that.
That's good.
And then maybe we can segue to the more recent outbreaks. So, look, Australia had an incredibly fortunate experience of the pneumonic influenza, as we called it here, or Spanish flu pandemic. So, worldwide, we think that it killed about 50 to 100 million people. And putting that into perspective, all of World War I, including genocides as well as combat and civilian losses, led to about 17 million deaths. So the Spanish flu conservatively killed 3 times as many people as World War I did in half the amount of time, and possibly as much as 6 times. The death rate in many non-Western countries at the time is not known. So in Africa and in India, for instance, we simply have no good estimates of how many people died or what the death rate was. In the Western countries, particularly in Europe and in the United States, the death rate was often about 2% of the population. In New Zealand, it was much lower, but it was still reasonably high. But in Australia, it was 0.2% of the population. In other words, 2 people in every 1,000 of the population died from pneumonic influenza at that time. So the overall death toll in Australia, we think, was about 15,000 people. It's not entirely clear because, of course, not everybody's death certificate says pneumonic influenza or Spanish flu. They may have died from pneumonia. They may have died from heart failure or other conditions that are not easily pulled out of the historical records. But that number's quite small compared with the global burden. And again, to put that in historical context, about 15,000 Australians died each year fighting in the First World War. So I sometimes say that 1919 was like the 5th year of the First World War. It's just that it was fought on the home front against a different enemy, but with similar risks and a similar death rate. So that's the historical background. David?
So thanks, Peter. I have to say, I'm often, having studied this in a lot of detail, I'm often fairly skeptical of figures that are mentioned about the number of deaths, and for the reasons that you mentioned, Peter, where death certificates often don't record, or even the certifying doctor would not even know, for example, that someone had an influenza infection that precipitated a cascade of exacerbation of existing illnesses, for example, that led to death. But these days, I estimated around 1,000 people on average. It depends, again, it depends how you slice the data, but around 1,000 people die on average, and as many as 3,500 people can die in a year from seasonal influenza, mainly very elderly people. And that, that's in a very severe season. I think the other thing I looked at last year was a study comparing, I was able to get data on the estimated deaths from Spanish flu, or the pneumonic influenza epidemic in New York City in 1918-19, and compared that with COVID-19 in New York City last year, which was a relatively uncontrolled, they did put in a lot of measures, but because it was so early in the overall pandemic, a lot of deaths did occur. The virus was circulating relatively freely, and I estimated that the pneumonic influenza of 1918-19 was around 7 times deadlier than COVID-19 in New York City. However, that was COVID-19 was 14 times deadlier than severe seasonal flu in the US, and 59 times deadlier than the swine flu pandemic of 2009. So, I think COVID does stand out as a very dangerous virus.
Thanks, both. The next question from Charmaine's interesting. She's wondering about how public health orders and advice were disseminated to the public in the years before daily TV press conferences. I think, Peter, you might have something to say on that.
Yeah, and I might ask David to reflect on the differences maybe when I've answered as well. Yeah, look, obviously it depends which period we're talking about. In the 19th century, communications were really quite limited. There was a good range of newspapers, but of course not everybody could afford a newspaper and not everybody could read. And I think that's something we often forget about, the low literacy rates really up until the 1870s when compulsory schooling took off. So a lot was word of mouth. There were proclamations. If you go back into archives, you'll find literally posters or bills that were stuck up on walls to proclaim a quarantine and warn people about circulating diseases. We only really started to see the telegraph coming in the 1850s and particularly taking off in the 1860s. But really that was the system in place until after the Spanish flu pandemic. So even in 1919, there was no wireless radio. There was no broadcasting of any description in Australia in 1919. So it did come down to community conversations, people actually going around and sharing information. Certainly the newspapers were really critical at that time, as well as the circulation of regulations that might have been shared on handbills or in letterbox drops and those sorts of things. And one simple example is that in Sydney, for instance, residents in many affected areas were given in their letterbox or on their doorstep a piece of cardboard, which on one side had a yellow, basically just a yellow sign that they would put up in their window to say, this house is infected, keep away. And on the other side, it would have SOS, save our souls, which meant we are infected, but we need help, and then so a health worker or a community member would come up and knock on the door and say, well, what do you need? They say, well, look, both the adults are sick. We need someone to look after the kids, or we've run out of food. Can you bring us soup? Or we don't have enough blankets. Can you bring some of those? And so even at that basic level, effectively letterbox dropping, they were the main means of communication, say 100 years ago. I don't know if David wants to reflect on how things are a bit different today.
Well, the simple answer is the internet. But I guess on that, everyone has access to the internet that we know, but I do have concerns that not everyone, the people who talk about, like us, who talk about these things, are fairly technologically literate, but there are people out in the community who are not as technologically literate as we are, and they do need other measures. And certainly as I understand it, there are many different modes of communication, radio, television, video, YouTube, that are being used to communicate to people in different languages. We have a much more complex, we have a very complex population now, multicultural population. They need to be communicated in ways that are communicated with in ways that are culturally appropriate and culturally comfortable, I guess, for them to relate to. And so, I think it's still the endpoint is the same. I was thinking, as you mentioned, the people putting a sign up in their window, Peter, wouldn't really work today because it's the people who we don't know that are infected yet that we need to worry about. And that's why, fortunately, we have the technology of testing people these days to get a better handle on that.
There's an interesting question here from Michael, I think it is. How far back does quarantine go? Michael suggests there was knows an example in the 1660s in the UK, but Peter, perhaps you could go. What's the origin of quarantine?
Yeah, I mentioned that earlier in my presentation that really the modern idea of quarantine, at least in the West anyway, dates back to about the 1350s with the bubonic plague that spread right across Asia and into Europe. So that's where we started to see the very idea of separating people who were sick with a disease that was believed to be able to spread from person to person, keeping them separate from healthy people, and particularly keeping populations separate from each other. So, and that was the origin of the idea of keeping them away for 40 days. It's not entirely clear how the 40 days was chosen at the time. I suspect it was mostly to do with the biblical allusions to 40 days, particularly with the Great Flood. But it was definitely that point where at least quarantine for bubonic plague came into play, and you did see it, yes, in the 1660s, particularly with the Great Plague that ended in Britain, at least with the Great Fire of London, and with some of the other plague outbreaks as well. It applied to certain other diseases, but we have to understand as well that diseases were understood in very different ways in the past. And a classic example is influenza. The very word influenza actually means influence, and it was believed that people became sick almost randomly in the population because of the influence of a change in the weather, or because of the environment they lived in, or a bad conjunction of the stars in the sky, or a meteor, or some sort of dreadful religious crisis where people weren't being faithful enough. And it was seen as those elements in the world were influencing individuals to become sick in a way that's completely alien to how we now understand influenza spreading via a virus between person to person. And that understanding was still partly in place even in the 1890s when we saw the pandemic of what was often known as the Russian or Asian flu. And I've seen examples in, for instance, the Australasian Medical Gazette from the 1890s, where a doctor is saying, well, there's several cases in the one house. Some of them seem to be spreading from person to person, but other cases appear to be developing spontaneously. So even as late as the 1890s, there are these two different ideas of influenza in the same household, in the same mind of a local doctor. So these things change over time, but they certainly affect how we roll out the idea of quarantine.
Thanks, Peter. We're just going to go over time for a few minutes because there's so many questions, but we won't be able to get to all of them. But there's a couple of questions about cabin spraying in aircraft. Has it been discontinued? And what was it doing? What were they trying to prevent? I'll leave it to either of you to answer that one.
I did look into this because I was wondering the same thing myself a little while ago. My understanding is it still happens, and but it happens when people aren't on the aircraft. So I think it happens between flights now. But I'm not 100% confident about that, but that's my understanding. And the reason it was done was to kill basically mosquitoes and possibly other vectors, so that could bring diseases to Australia, like malaria or dengue fever, for example, which are carried by mosquitoes.
Yeah, and I would just add that that practice came into play in 1934 with the change of the Quarantine Act, which was where the initial concerns about these disease vectors coming in via the cabins of aircraft were first put into operation. So aircraft did have to be disinfected, usually when they were taking off as well as when they were landing. And so that was for aeroplanes, but that longer term practice known as fumigation actually went well back into the 18th century, particularly the 19th century, where particularly sulfur gas or sulfur was burned with the idea partly of warding off evil. And I think we have to acknowledge its sort of older origins in that sort of magical period. But gradually it was seen that burning sulfur or putting in other poisonous gases, including, for instance, nitrogen cyanide into the holds of ships when there was nobody on board, might kill animals like rats, as well as any insects that might be carrying diseases on them too. So it's an older practice from the maritime world that moved into aircraft in the 1930s.
Interesting. Robert has a question. With hindsight, is there a case for reintroducing old style quarantine stations?
Well, in my opinion, we already have them in a different form. You know, people are quarantining in hotels at the moment. It's partly maybe we have a better sense of treating people fairly, but essentially the end result is the same. We treat people well, we make sure they're fed, we don't rely on them to provide the resources to stay or to stop themselves bringing the disease into Australia. We know that people need to be cared for and looked after while they're in quarantine. And I guess North Head is quite a nice place to be in quarantine if you are there, though. But on the other hand, people have other needs that need to be met.
I'd add from the historical perspective that North Head Quarantine Station was a very busy place from the 1830s until the 1930s, and then really it became a ghost town afterwards, and that was largely to do with better health screening of people coming aboard ships and the mass uptake of vaccination, particularly in the 1940s and 1950s, as well as things like x-rays for tuberculosis for people who were travelling to Australia. So there were many reasons why, really from about 1950 until it closed in 1984. The quarantine station in Sydney and many of the other Australian quarantine stations just sat there empty, maybe occasionally quarantining people who didn't have a valid vaccination certificate. Didn't mean they were sick, it just meant that they couldn't produce the documents to prove that they might not spread smallpox. And so they sat there for 30 years waiting, requiring expensive upkeep, taking up a lot of real estate and not being used. And so that's why really in the 1970s and 80s, most of them were closed. And ironically, last year, as COVID was starting to ramp up again, I know this from the people who operate the quarantine station at the moment as a tourist facility, they offered the state government the possibility of reinstating it as a quarantine station, given its history, given its location, given how well care could be provided there. But it was actually turned down partly on account of the facilities, which were not designed anymore, they're no longer appropriate for modern day healthcare, but also because it's a very hard place to patrol. And I don't know that we would have seen people popping out with COVID to go down to the pub for a beer in the way that they did, say, in the early 20th century when they were quarantined for smallpox. But it is a large place and it is hard to police in a way that hotels aren't anymore. Hotels are much more self-contained and much easier to manage in that sense.
Thanks, guys. I think this is the last question. I think a good one to finish off a bit of future thinking. When Andrew asked, when international travel reopens, what do you imagine the quarantine regime will be like? Do you think home quarantine is feasible with current strains of COVID? Perhaps, David, you could respond to that.
I think the important thing there is that the need for quarantine is about managing risk. So if we've become if we've accepted the fact, if COVID has become part of the background range of pathogens that we're exposed to in our daily lives, like influenza, and like the common cold, and the risk is the same in Australia or similar to source countries, then I don't see why we would need quarantine. I think, but I think maybe, well, I guess one thing to consider is that the Delta variant is already not the last variant that's arrived, and there may be other variants that are either less severe or more severe than the Delta variant. And in terms of transmissibility. So I'm glad I thought my dog was going to bark, so that's good. It hasn't happened. I think, yeah, look, I think there'll be a time where when enough people are vaccinated, we'll find it acceptable to quarantine at home. But again, there's going to come a point where the risk in Australia is going to be similar to the risk overseas. And we just, the idea of quarantine won't be relevant anymore. But again, I can't say when that might be.
Well, thanks so much, Peter and David, and everyone for your really great questions. I'm sorry we couldn't get to all of them, but this brings us to a close. But before we go, just want to draw your attention to the upcoming History at Home events, which you can see on your screen right now. Every week, History at Home has a different topic and a different format as well. So please visit the website, c.museum, for the latest schedule. And just before we go, I wanted to note that this week, as it is International Talk Like a Pirate Day on the 19th of September, we've got 2 History at Home events this week. So on Friday night at 7 p.m, we have the Great Big Pirate Quiz. This piratical trivia session will be hosted by the museum's resident pirate. Yes, we have a resident pirate called Captain Grognose Johnny. You can find all the details on the museum's History at Home page, and I'm sure the whole family can join in. So thank you very much, everyone. Have a great evening.